So what are the risk factors for anastomotic leaks? Three types: major, contributing, or modifiable. And they're interesting because research has shown that there are statistically significant factors that have a direct influence on the risk of complications, but there's also contributing factors that are associated with it, but their significance and prevalence have not been determined. And most importantly, there are risk factors that are modifiable. In other words, you can treat them or control them and prevent anastomotic leakage beforehand. And that's why it's important to talk about and think about risk factors that can be determined beforehand. How are they determined? Well, the risk factors most often are determined by multivariable analysis. Now, I have to talk to you a little bit about statistics because the same problem that occurs with propensity score analysis occurs with multivariable analysis. In other words, the results of multivariable analysis, as the results of propensity score, depend on how you collect the data, how long you collect the data, and especially what variables you are using, what population are you studying. And all of these factors are not always available or not always known. And when you do a multivariate analysis, it's not because you do a multivariate analysis that it's better than a randomized trial. It cannot be better because it's dependent on what you put into it, like the propensity score. So they lead to a problem of generalizability. The possibility of extrapolation is reduced because of that selection bias. Anyhow, we do talk about risk factors, and they are important. There's another problem when we talk about risk factors for anastomotic leakage and the rates of anastomotic leakage, because there are more than 50 definitions of anastomotic leakage. However, today there are two that have to be retained. The most widely, by far and large, the most widely used definition is the one from the ISGRC, the International Study Group of Rectal Cancer, published in Surgery 2010, and a modification that was done by William Chen and myself in 2019, that indicate that the definition is a defect in the intestinal wall at the anastomotic site, leading to a communication between the intra and extraluminal compartments. The American College of Surgeons NSQIP database was also studied in 2017, and they came up with another definition of anastomotic leakage being the leak of endoluminal contents through an anastomosis, and including air, fluid, gastrointestinal contents, or contrast material. They wanted to make sure that not only do you have a defect, but you also have a communication that's materialized. But they added also something very important, which is the presence of an infection or abscess, even though the leak cannot be considered or cannot be definitively identified. They leave it up to the discretion of the surgeon, but this is something very important. You can argue that this would maximize the leakage rate in some studies, but this has to be done in order to be honest. And in all the studies that we have performed in the investigational studies that we've done, mainly in France, but in Europe in general, all these multi-institutional studies, multi-center studies have made a very large definition of anastomotic leakage, including leaks that were materialized, but also any patient that had one or more infectious complication. And they were probably overrating the anastomotic leakage rate, but still there may be infraclinic intestinal leakages or leakages that wall off, and you don't have any more leakage, you don't have any communication between the two compartments, but still have a leak that has occurred that's responsible for the abscess. So the definition should be large. And then there's a severity classification that goes with the international group that has been put forward. And this is where we made our modification, but we had to include laparoscopy. So the risk factors are related to several factors. Let's take a look at these one by one. The location, the technical aspects, mechanical aspects, the blood flow, and patient factors. We all know that there is a decrease, or let's say an increase as we go from right to left in the risk of anastomotic leakage. So the right column leaks much less than the transverse, and the transverse much less than the descending. And probably the reason is the vascular problems that we talked about, in other words, the Drummond artery and the Sudeck vascular point, the watershed area between the left colic and the middle colic arteries on the splenic flexure. There's another factor that intervenes when you're talking about rectal cancer and rectal anastomosis, is that the lower rectum has no serosal co-reveling. And so any longitudinal tension on the rectum is only going to depend on the mucosal aspect of the vascularization, and we don't have any serosal reinforcement. So the other factors that lead to anastomotic leakage can include defective healing, infection, the microbiome theory, increased intranuminal hyperpressure, faulty technique and mishaps that we'll talk about, and we've already talked about the insufficient blood supply. Intra-abdominal hyperpressure can also lead to mechanical tension, which is another factor of anastomotic leakage. This leads me to talk a little bit about stapling. Everybody uses staples today like they use a fork and a knife. And I was surprised to learn about the dynamics of tissues and staple formation very late in my career. So I hope that you will be aware of this early in your career so that you take this into consideration when you use stapling devices. There is a whole theory of compression with what we call the creeping effect and the shearing effect. There is a relation between the staple leg length and tissue thickness that has to be respected. I've already talked about the untoward effects of crossing staple lines, and I'll talk about that a little bit more. And there also is a lot of material out there to understand the best way to for an anastomotic not to leak is to have correct healing. Let's talk about the staple height to begin with. You all are aware of the different types of cartridges that we have, the different staple specifications. You have to realize that the staple height is something that is very, very specific to the tissue that you are interested in. And the staple height can vary from little less than 1 millimeter to 2 millimeters, according to the color of the cartridge. And what does that mean? It means that when the staple formation is correct, the hemostasis is better. And the equal height, let me take the
ETS-45 with a blue. Seconds.
I want you to listen
to
see what's happening here, but I have to take off the sound.
Which means it delivers 0.5 millimeter tighter staple. Approximately 5.5 millimeters of tissue thickness, very good staple form. The endo-GIA is positioned alongside the ETS transection. It is closed, and then the device is slowly actuated.
Take a look at the angle that is being performed here. The jaws are not completely closed. This is because of the tissue thickness. If you do not wait before you fire the stapling, you're going to have an unequal distance between the jaws here and here. And the staple formation here will not be complete. Does everybody understand that? See the angle here? Here is the angle of the lower jaw, and here is the angle of the upper jaw. They are not parallel. They should be parallel. So waiting.
Now, to demonstrate proper compression, the ETS-45 with a distance at a time. This allows the I-beam to create the same type of compression that the surgeon enjoys with the ETS-45 automatically.
See how the jaws are closing?
On the top and a shoe on the bottom.
As the time goes by, the two jaws become parallel.
If it is done now,
see how the jaws become parallel? Here they are not. Now they're parallel. And if you wait sufficient amount of time, you have a correct anastomosis.
Those are complete, well-formed staple lines.
Good, well-formed staple lines. Okay, so you have to wait for 20 seconds. There's also the creeping effect that I'll talk about in a few minutes. Okay, I'll talk to you about the vascular problems of the related to the stapling. Don't need to go through that again. What about the other factors? Colonic preparation. I don't have any slides on this because there is no conclusive evidence that colonic preparation reduces or not the anastomotic leakage rate. There are so many publications about what you should do to avoid infectious complications, surgical site infections, all the information about anastomotic leakage is riddled with false statements. The only correct studies are those that included polybetadine or povidone iodine in the anastomotic preparation or the colonic preparation, but no one has abided to this in the present day. So it's something that does not have its importance anymore. Theoretically, once you have finished an anastomosis, you should look for the donut integrity, whether the donuts are complete or not. You see the example here of a complete donut on the proximal and on the distal, or on the distal and the proximal segments once you have performed the anastomosis. If they are intact, it doesn't mean that you're not going to have a leak. But if they are not intact, there certainly is an increased risk for a leak. I personally look for the donuts, but I don't pay that much attention to them. I personally rely on two other investigations. One is the endoscopic inspection. If it's a low anastomosis, it's easy to put a scope into the anus and verify the integrity of the staple line, of the staple line, even injecting a little bit of air, see if there's any bleeding, any areas of ischemia, and you can even do ICG and look at the mucosa from the inside. I have a video on that, but time will not allow me to show everything. I do like to insist, however, on testing for air tightness. Now, you can do this in several ways. You can do this by injection of blue or air. And I really insist on the fact that you should not use blue. Blue is not enough. You have to use air. The reason is that when you use blue, if you have a leak and you do try to repair it, and then you redo the test, you don't know if the blue is coming from the first test or from the second test. So whether it's an intra-abdominal or a colorectal anastomosis, I always test for air tightness. This is a traditional air test. But you also can do it in a different way, and it's called the reverse air test. In other words, in the traditional air test, the air is injected through the rectum where the intestine bathes in the abdomen, in the saline, in the abdomen, and you look for bubbles. The reverse test was popularized by Spinelli in Italy and Wexner in the United States, is when air is injected through the abdomen, where you put bubbles where you put the saline in this case,
and completely unexpected repair is tension-free by gently withdrawing the transanal retractor.
If there's a leak, there was a leak, and then a suture was performed, and then there is no leak. And the second time, the air test was performed. So testing for air tightness from the abdomen or from the inside out or outside in, both are are ways to do it. Don't forget the stump. I always test for air tightness of the stump before I do the anastomosis as well. And Wexner in 2019 said that there should be a quadruplet technique, and I would add there's a fifth to that quadruplet technique, which is the stump. So you test for air, you look for the endoscopically, you do ICG, and you look for the donuts. They're all valuable ways of testing. Now, let me talk a little bit more about the ICG. I've talked about it. I want to go into a little bit more details of how it's done. Indocyanine green is a dye that was used for photography. And actually, more than 50 years ago, the Mayo Clinic used it to perform angiography for the retinal veins of the eye. The basic quality of endocyanine green is that it is not metabolized by the human body. It binds with albumin and is removed fairly quickly by the liver, and it goes into the bile. And this is why it's used very often nowadays for intraoperative cholangiography during bile duct surgery. The toxic dose is very high. We saw that before. So that means that the investigations can be repeated. Now, it works in this way. It is a dye that binds to the plasma and goes into the vascular bed. And then when you irradiate the tissues with near infrared light, which is 805 nanometers in wavelength, this excites the ICG, which becomes fluorescent. And if you have a camera that's capable of detecting that fluorescence, you get a vision of what the protein that's carrying the ICG. And these special cameras or telescopes are readily available, as I said today, either with Storz or with Stryker. We've published on this extensively with Luigi Boni, and there's even a pamphlet that's available from Storz on all the applications of ICG. I have some examples here. I hope the videos are going to work. Coming from Luigi Boni when he was working in Varese. Now he's in Milan. This is an example, extra peritoneal. There's a preparation of the colon. You may seem that it would be vascularized completely at the point where the staple is. This is the staple. The staple is indicative of what we think is going to be the resection line. Here's what it looks like once you inject the ICG. You can see the vascular supply coming into the Colin, up to the exact place where the staple line is. So you can be sure that if you do an incision just to the left of that margin, which is very difficult to see on white light, you can be 100% sure that the end is vascularized. Once again, it's not because it's vascularized that it's not going to be leaking, but it is at least a guarantee. The other is another example of the same thing. So we're not going to insist on that. This, I think we've already seen. Now, I have other examples. We don't have the time to go through them all. But here you have an example of the mobilized column for the splenic flexure. And here you have an example of a ilio transverse anastomosis, making sure that the vascularization is adequate before you do the anastomosis. And then there's the example on TME. Okay. I'll have to go back to that once we get to that in the end of today's talk. So there's adequate information out there saying that ICG reduces the risk of detection. What is very interesting, however, is a study that I'm going to show you in a few minutes that just was published by Wexner, saying that if there is a leak, it's not 100% sure that if you repair the leak after ICG, that you're not going to have a leak. This is the pillar study that was performed, the pillar 2 study that was performed in the United States by Mike Stamos and his group. Wexner was one of the participating surgeons, Senegor also, and regretted David Margolin, where they showed that the change to resection margin, they decreased the rate of anastomotic leakage, to the contrary of what the 2022 study has shown. We'll talk about that in a few minutes. So this is the experience that we had when we looked at that results in Italy, where we saw that ICG was possible in 100% of the cases. It led to a change of point of transection in 4 cases, and we had an anastomotic leakage rate still, but it seemed to be very interesting as a prevention. So there are studies that have looked at the literature and have performed meta-analyses, and this is the latest meta-analyses coming out of Italy by Roberto Ceracchi and his group, where they said that the use of ICG to assess anastomotic blood perfusion leads to a significant reduction in anastomotic leakage. I don't know how they were able to determine that, but that's what they say, as well as the need for surgical reintervention, especially in the patients. There was no comparative study, so I don't know how they can say that. But anyhow, they did say that. And this is the study that I was referring to that was just published by Wexner. No, this is not the study I was referring to. This is another study of a expert opinion where we evaluated, I was one of the contributing authors of this, where we were asked different questions as to what was the ideal dose, what was the ideal timing for evaluation of colonic vascularization. And the consensus was it was between 5 and 10 milligrams of ICG, and 30 to 60 seconds before you try to see them. You need at least a minute in order to have a full visualization. Now, the lines should be flushed with saline, but the ICG powder, which comes in a fuel of 25 milligrams, should be diluted half and half. And when it's half and half, you dilute with the 25 millimeters, which corresponds to 20 cc's, with the 10 milliliters of distilled water, not saline. Very important that you don't use saline to dilute the ICG. And yes, there's another meta-analysis that came after the Italians. They said the same thing. ICG reduces the anastomotic leak. The rate is much lower, and here they had significant heterogeneity. They looked for heterogeneity, which the other study did not. And then in surgical endoscopy, Wexler just published this paper, which is a little bit different. In other words, they said that, first of all, the systematic review included 27 patients. It's the highest amount of studies, and they looked at the change in surgical plan and whether it influenced the leak. It was very difficult to perform because, first of all, there was a lot of heterogeneity due to the differences in the dosing of the ICG. You can see how that varied from one study to another. And they said that it was likely to be associated with lower odds of anastomotic leak than traditional white light assessment. However, when the ICG detected something wrong and the surgeon decided to change plans, there was a higher odds of anastomotic leakage. What does that mean? That means that perhaps once you detect a defect with the ICG, there is no correct way of determining where you should cut the intestine in order to have a better vascularization. Or it may be during that operation or that procedure that you interrupt the vascular supply. It remains to be determined. So there's still some work to be done here. There are still randomized trials underway. 3 studies have been published. The Pillar 3 was the continuation of the Pillar 2 study by Stamos in California. They were unable to show that there was any difference, but the study was discontinued early because of troubles with patient accrual. They couldn't get the amount of patients that they needed. But even though they did a worst case scenario, there was no significant difference in the results. The Italian study by Denardi was performed and completed, published in Surgical Endoscopy in 2020. They had a difference, but that difference was not significant, even though it looked twice as much. And the only study that did come out with a statistically significant difference is a Russian study, the FLAG study. But the only significant difference was in the subgroup analysis of the low colorectal anastomosis. In other words, anastomosis between 4 and 8 centimeters from the anal verge. There are still 3 other studies that are underway, 2 from the Netherlands, and 1 from the UK, but we still don't know the results of these studies. So, in conclusion, prevention of ischemia depends on remembering what the anatomy is about, making sure that your dissection is complete, careful. Make sure that your anastomosis is without any tension, any twist. Probably there's a routine, there's a need for routine ICG. There is a need for checking your anastomosis from the visual point of view, from the endoscopic point of view, from the IC point of view, and testing for air tightness. And then to make sure that you have any correctable patient factors beforehand. For instance, making sure the patient has good diabetes control, trying to control for hypotension during the operation, making special attention, taking special precautions to the person with a cardiovascular problem, with a cardiorespiratory problem. The sitting chair or the sitting chair position, as opposed to the anti-Trendelenburg for operations and especially in the obese patient, taking care that the operation doesn't last very long and being sure that there's no compression problems. All these have their importance in the outcome that can lead to intraoperative events that influence the rate of anastomotic leakage.